Okay, good afternoon again. So a few more people have joined, but I think we should start here since we're going to be covering um, topics for both Wednesday and Friday sessions in this session. Okay, so as usual, what I will do is I will show some photographs. I'll ask you to describe what you're seeing in the photographs. We'll make a decision about what pathology is being represented and then have a little bit of a discussion about that particular topic. So we'll start with this photograph and I'll ask someone to describe what they're seeing. So remember to start with what organ you think is being represented, whether it's the external surface of the organ that you're seeing or the cut surface, and then describe what is present. So who'd like to go ahead?
Are we looking at a picture of a heart?
You turn your volume up just a little bit, please, Matthew.
I was wondering if we're looking at a picture of a heart, perhaps?
Um, so no, not. I'm going to point to something in a minute, Matthew. For you to look down here and then tell me. You may see this structure coming off here. So I see that Kyle said kidney. Okay, Danae also said kidney. So I agree with those answers. So Matthew, do you appreciate that it's kidney now? So if it is kidney, what structure do you think this is that has been cut? So it would normally be longer. It has been cut
That would be the
here.
urethra?
Fabulous. Yes, that's the urethra. So we have the lower pole of the kidney here, and then there's something happening in the upper pole. Matthew, do you want to describe this for us?
I'm trying to think of the words to describe it. I'm,
Well, what do you see? Do you see a mass? Do you
yeah,
see a,
it's,
okay. Mhm.
yeah, there's clearly a mass there, so the structure is much larger than it's supposed to be. Um,
Okay, so there's a mass in the upper pole of the kidney. Okay, what can you tell me about the mass?
oh boy. Well, it's well circumscribed.
Okay,
Trying to find the words for what's obviously in front of me, but
all right.
what can you
So
tell me
you're
about
saying
it?
that there's this circumscribed mass in the upper pole of the kidney. Okay, fabulous. And tell me about some colors that you're seeing.
So definitely seeing some yellow. Um, what colors do you even use to describe the rest of it? It has a fleshy appearance. The
We're seeing
surfaces are
multiple colors.
irregular.
Mm-hmm.
Yeah,
Okay, all right.
between
So
brown,
you
red,
said there's
yellow.
okay.
Mhm.
So there's some yellow areas, some more tan, tan to pink looking areas, and then you're saying there's some areas of hemorrhage. You said some red areas. That's meaning like this, for instance, there's a hemorrhage.
Right, right. That's another one further below.
Okay.
Yeah.
All right. Fantastic. Thank you, Matthew. So we have this large mass. There's no scale in the photograph, so we can't really tell the size of the mass, but it seems to be almost dwarfing the kidney, right? So we know it's a really large mass that appears to be arising in the upper pole of the kidney, and it looks circumscribed, has these yellow areas as well as tan pink areas and areas of hemorrhage. So based on what has been described, can I have a volunteer to tell me what they think is going on here? What kind of a mass do you think this is? Is it an inflammatory mass? Is it a neoplastic mass? What do you think is going on? Okay, so I I have multiple answers indicating neoplastic, so I agree. Okay, so we have a neoplasm here in the upper pole of this kidney. Do you think this neoplasm is benign or malignant? So Matthew or Tanya or Marshall or Kyle, can you tell me why you think it's benign? Okay, so we know that with benign tumors, the margins are well circumscribed as shown in this lesion. So that's one main characteristic of benign tumors. However, in medicine, we know that there are always exceptions to the rule, and this is one example of a case in which a malignant tumor is exhibiting this circumscribed appearance. So in fact, and we wouldn't know for certain until we took a section and looked at it under the microscope, right? That this tumor is in fact a malignant tumor. So if I tell you that this is a malignant neoplasm of the kidney, going on the basis of what is common, what do you think this is most likely to be, just based on statistics? So in other words, what is the commonest malignant neoplasm that we would encounter in the kidney? Tavia, is that where that tumor arises? Where does that tumor arise, Tavia, that you mentioned? Okay, so I have office. Excuse me 1 minute, guys. The office phone is ringing. Yeah, sorry about that. So I saw multiple offers of renal cell carcinoma, so I would agree with those answers that this tumor is renal cell carcinoma. So Tavia, I was asking you, you wanted to change your, fabulous. So the answer that you suggested is a tumor that arises in the medulla of the adrenal gland. Okay, so we're all on the same page now. So this renal cell carcinoma, by virtue of the fact that we call it a carcinoma, that means that it arises from what type of cells? Is it mesenchymal cells, epithelial cells, hematopoietic cells? Okay, fabulous. So this is a tumor that arises from epithelial cells. So which structures in the kidney might have epithelial cells from which this tumor could arise? Think about the histology of the kidney. Fabulous. So Kyle says a tubule. So in fact, renal cell carcinomas arise from the epithelium that lines tubules. And depending on which type of tubule, as you recall, there are different types. Depending on which type of tubule or duct this neoplasm is arising from, then it falls into various different subcategories of renal cell carcinoma. So there are different histological types of renal cell carcinoma that exist. Now, the fact that they're arising from tubules, what kind of carcinoma would they be? So remember that we have different types of carcinoma depending on which type of epithelial cell they arise from. Remember the types of epithelial cells that exist? So, okay, so Tanya says adenocarcinoma, yes. So by virtue of the fact that they're arising from epithelial cells that line tubules, which would be the same as those that line glands or ducts, then the malignant neoplasm that would arise from them would be adenocarcinoma. So all renal cell carcinomas are adenocarcinomas, but different histological subtypes of these adenocarcinomas exist. And we'll discuss in a moment when we come to talk about the histology. So that's a tubular epithelium. Could we get a different type of malignant neoplasm arising in the kidney from epithelial cells, but not tubular epithelium? Where else could we find epithelium in the kidney? Different type of epithelium now, so not tubule forming epithelium, other epithelium. Where could we get those? Where could we find those? No, good thinking, but no. What? Okay, so a lot of the area that would contain this epithelium is not depicted so nicely in our kidney here. Well, you know, most of the upper pole is gone, but you know, if you can imagine here continuing into a system. So when you look at the kidney, let's say you have a normal kidney and you've cut it, you've seen the cut surface of the kidney as you are here. What are the things you'd see? What do we call out here? This outer rim would be the cortex, and then after the cortex we have the what comes, then there's the medulla, and then what do we have that's going to then converge into the ureter? Right, so we have the pelvic calyceal system. So what epithelium lines the pelvis, the renal pelvis, and the calyces? It's the same epithelium that continues into the ureter and down into the bladder. What epithelium is that? Yes, so it is transitional epithelium, and this special type of transitional epithelium that occurs in the urinary tract, we give it a special name. What do we call it? No, so that would be describing how these cells are arranged, right? So remember, epithelium, if it's in a single layer, is simple, but in multiple layers, it's called stratified. So stratified is a reference to the arrangement of cells. But in terms of the name of this type of transitional epithelium that is found in the urinary tract, urothelium, fabulous. And so the carcinomas that arise from this urothelium, what do we call them? So urothelium gives rise to what type of carcinoma? What type of carcinoma? What type of carcinoma? Think of the name. You haven't heard that name before? Fabulous. Urothelial carcinoma, right? So if what we had here was a urothelial carcinoma rather than a renal cell carcinoma, then the tumor that we would see would be filling the pelvic calyceal system instead of something that is arising from the parenchyma, arising from the epithelium of tubules, all right? So a parenchymal lesion, renal cell carcinoma, versus what could exist, a pelvic calyceal lesion, urothelial carcinoma. All right, so this parenchymal lesion, this renal cell carcinoma, which we have said is an adenocarcinoma, what's the commonest risk factor for it? Fabulous. So tobacco is the commonest risk factor for renal cell carcinoma. Are there any other risk factors that you can think of that you can tell me about? So not so much recurrent infection. Okay, we'll come back to that. But yes, family history. So there are inherited syndromes in which renal cell carcinoma is one of the components. So not so much recurrent infections, but there can be other diseases of the kidney that can predispose. Um, which ones? So usually patients with a certain final common pathway of many diseases receiving a certain type of treatment may be at risk for developing renal cell carcinoma. What am I making reference to? Final common pathway. What condition may complicate varied renal disorders? So something chronic, therefore. Okay, so not what I was getting at, but yes, hypertension is also a risk factor for renal cell carcinoma. So far we have cigarette smoking, we have hypertension. So renal cysts, yes, so acquired cystic disease is a risk factor. What else? What other kind of condition can patients have that require them to be seen a nephrologist and to be getting a certain type of treatment? The frequency varies for some people, maybe twice a week. Some people might need it 3 times a week. Okay, so right. So patients with chronic renal failure, particularly if they're receiving dialysis, may be at risk for the development of renal cell carcinoma. Okay. So we have cigarette smoking, hypertension, inherited syndromes, acquired cystic disease, chronic renal failure, anything else that individuals could be exposed to because of occupation, maybe? Okay, so various heavy metals may predispose to the development of renal cell carcinoma. Okay, all right. And asbestos, another important risk factor, yes. And chronic exposure to petroleum products also may increase, exactly, increase incidence, increase susceptibility to renal cell carcinoma. Okay, fine. So by far, cigarette smoking, the commonest identifiable risk factor, but then others as we have listed. So you told me that one of the risk factors is, having one of these inherited cancer syndromes. So what syndromes are you talking about? Tell me some of the names. What syndromes that were you thinking of when you said genetics and you said inherited or familial? What syndromes were you thinking of? Just give me one. No, so polycystic kidney disease is a different disease. Remember that the cysts associated with the development of renal cell carcinoma are actually acquired cysts. Now, some of the syndromes may also see patients having renal cysts as part of the syndrome, but polycystic kidney disease itself is a separate entity. So I see two answers here. I saw VHL and I saw tuberous sclerosis. So both are correct. What does VHL stand for? What does VHL stand for? Von Hippel-Lindau. Fabulous. So what are the components of the von Hippel-Lindau syndrome? So apart from having a renal cell carcinoma, what else would the patient with VHL have? So they can have renal cysts, yes. What else? What else could these patients have? Excuse me. Yes, they could also have pheochromocytoma, another important and common feature of the syndrome. So apart from renal cysts, could they have cysts anywhere else? Not so much in the adrenals. There's not cysts. Well, where else could they have cysts? Okay, so they may also have cysts in the pancreas. All right. So another important tumor that you haven't told me yet that is a component of von Hippel-Lindau syndrome. What tumor am I looking for? I tell you that this tumor can occur in the cerebellum, can also occur in the retina. What tumor am I talking about? Another important component of VHL syndrome. No one remembers? Okay, so remember that they can have hemangioblastomas, right? So not retinoblastoma, which is a different tumor. They'll have a vascular tumor known as a hemangioblastoma, and this can be found in the cerebellum as well as in the retina. All right, and of course, other syndromes can exist. So there may be a hereditary papillary carcinoma syndrome, for instance. So that brings me, therefore, to the discussion of what we made reference to earlier about the histological types of renal cell carcinoma. So we said that they were all adenocarcinomas, but when we look at these tumors under the microscope, they can have different morphologic appearances. And based on these different appearances, we put them into different categories. So does anyone remember some of the categories of renal cell carcinoma? So what type do we see in VHL? Which type of renal cell carcinoma do we see in VHL? Nobody remembers any of the subtypes of renal cell carcinoma? No? Okay. Do you remember words like clear cell renal cell carcinoma? And I just told you one. I said yes, so clear cell renal cell carcinoma, papillary renal cell carcinoma, collecting duct carcinoma, chromophobe renal cell carcinoma. Remember those terms from your lecture? And there's one that is uncommon, but we need to know about it because it is associated with a disease that is common in our population. So which disease am I speaking of, and which subtype of renal cell carcinoma may develop in patients with this disease? Anybody remembers the disease? Which disease am I talking about, in which patients can develop a type of renal cell carcinoma that is very aggressive, a very aggressive tumor? And if you remember the name of that subtype, that would be good. Maybe Tavia was thinking of this subtype when she told us about pheochromocytomas earlier. That's a clue to the name of the subtype. No, so remember carcinoids are separate. Yes, a medullary carcinoma, medullary renal cell carcinoma. And that occurs in sickle cell disease. So was first described in patients with sickle cell trait, but since the discovery, it has been seen in patients with actual sickle cell disease. So not just the carriers, but also patients with the disease. So just to clarify the response before, remember that carcinoids are really neuroendocrine tumors, right? So completely different from these straightforward carcinomas. So we speak of low-grade neuroendocrine carcinoma or neuroendocrine carcinoma grade 1 for carcinoids, which is the older terminology, but completely different from these adenocarcinomas, these renal cell carcinomas. Okay, so we have all these different subtypes. So Simsa, it would appear that you haven't really looked back at renal cell carcinoma recently. I'm not going to ask you now, but I'm going to ask you to please go back and review why we call these subtypes, why we put them into different categories. How is it that the cells look under the microscope, why we give them these different names? All right. So clear cell, papillary, chromophobe, collecting duct, and medullary. So go and read about those and to appreciate why we give them these different names. Right? Some are obvious. Right? If it's clear cell, then it must be that cytoplasm is clear. But we also want you to appreciate not just the morphology of the cells itself, but cells themselves, but how they are arranged as well. Right? So please go and read the histology of the categories of renal cell carcinoma. All right, so we'll move on then to the clinical features. So where renal cell carcinoma is concerned, clinically, a classic triad of symptoms is often described. Now, most patients don't present with this classic triad, but we still need to know what the classic triad is. So, what am I talking about when I mention this classic triad? How do these patients present? So I have this big mass in the kidney. Okay, fabulous. So there's flank pain or costovertebral pain. Yes, that's one of the three. Hematuria. Yes, that's another one. And what's the last one? Something, something you'd elicit on examination. Yes, so there's a palpable mass in the area of the kidney. Okay, yes. Fabulous. So those are the three features that characterize this classic triad with which patients with renal cell carcinoma can present. This classic triad really and truly seen maybe in just about 10% of cases or so, but we still refer to it. But so of these three symptoms, which is the one that patients most commonly present with? And they're therefore going to be investigated for this symptom. And during the course of the investigation, this tumor is going to be discovered as a cause of the particular symptom. Which symptom? The hematuria. Fabulous. Okay. All right. So that's by far the commonest presentation. All right. So patient presents with hematuria, is investigated, renal cell carcinoma is discovered, and kidney is removed. So there's a nephrectomy, such as the one that you're seeing in the photograph here. Sent to pathology. Sections will be taken so that the pathologist can look at it under the microscope and make a diagnosis, not just of the fact that it is a renal cell carcinoma, but to see what subtype it is, and to tell us other things about the tumor that we report for malignant tumors in general. So, how should this tumor be sent to the lab? Let's see. So we're talking about autopsy now. So our case was taken from a patient at autopsy. But suppose the diagnosis was made in life and the patient had a nephrectomy. How should that nephrectomy specimen be transported to the laboratory? Wow. Are we going to put in a container? Okay, I know it's Friday evening, guys. All right, yes, we're going to put in a container. We're going to put anything other than the specimen in the container. Fabulous. So we're going to put formalin. And how much formalin are we going to put in the container? So in relation to the volume of the specimen, am I going to put an equal volume of formalin or? Okay, a little bit more than 3 times. 10 times is a minimum, yes. So at least 10 times the volume of the specimen, fabulous, of formalin must be included in the container. Okay, so that was a bit of surgical pathology. We're speaking about autopsy today, but that was just for me to bring you to the evaluation of the tumor under the microscope and ask you, apart from the diagnosis, what else must the pathologist report? What are some of the things we report when we examine malignant tumors? Is there anything else we can say about the tumor? Let me look at the tumor. So if we have other tissues submitted, Daniela, yes, we can look to see if there is tumor present in those other tissues. So which other tissues am I talking about? So we're already talking about an invasive tumor, Daniela, so it would already have infiltrated the basement membrane. All right, so Kyle, we could have the tumor extending directly to adrenal gland. Yes, that could happen. So they could have sent adrenal gland, and they sometimes do, with a nephrectomy specimen. So excellent. Okay. What else could we have with the specific lymph nodes? Fabulous. So of course, lymph nodes could be submitted with the nephrectomy, and we'd examine those to see if tumor is there. All right, fabulous. So we can report stage. Stage being a measure of the degree of spread of a tumor, right? So we're looking in these various other tissues to see if the tumor has spread from the kidney elsewhere. What else do we report apart from stage? What's the other term we speak about when we speak about malignant tumors? We speak about stage and we speak about fabulous. We speak about grade. What is grade? What is grade? Well, the grade is something that we're going to apply to all malignant tumors, regardless of where. Aha, right, fabulous. So it is a measure of the degree of differentiation of the tumor. And when we speak of differentiation, what do we mean? You're going to explain to a first-year medical student, what are you going to tell them? What's differentiation? What are we measuring? What is it that we must be comparing the tumor cells to decide the degree of differentiation? Fabulous. So we're looking to see how much the tumor tissue resembles or does not resemble the native tissue from which it arose, right? So if it looks very much like the native tissue, then it is well differentiated. If it looks nothing like the native tissue, it's poorly differentiated, and somewhere in between, we speak of moderately differentiated. And in some grading systems, we use a two-tiered approach instead of three. So we speak of low-grade or high-grade tumors. Right? So when we look at this tumor, we have to analyze the degree of differentiation, and there are different grading systems that we use for different tumors. All right, so back to stage. So you told me that this tumor could spread to lymph nodes. You also told me that there could be direct spread, such as to the adrenal glands. So apart from direct spread and lymphatic spread, what other type of spread might occur with these tumors? Fabulous, hematogenous spread. So where might the tumor cells go um, through this hematogenous dissemination? Where may they end up? In renal cell carcinomas. Tell me some of the common places that renal cell carcinoma. Fabulous. So the lungs are actually the commonest site of metastases in renal cell carcinoma. Where else? So we have lungs. Where else? Bones. Yes. Brain. Fabulous. And one more. Another common site that a lot of tumors go, yes, to the liver. Fabulous. All right, so we can have hematogenous dissemination to these areas. Okay, so we know that malignant tumors in general can produce symptoms that are due either to the primary tumor or can be a consequence of metastasis. So for instance, if a tumor metastasizes to bone, as you have told me that this one can, it may actually cause a fracture, a pathological fracture in the bone to which it has metastasized. As a result of the bone metastasis, the patient may have hypercalcemia, for instance. However, in some tumors, there are symptoms that occur. There are certain clinical characteristics that occur that cannot be explained by either the primary tumor or the presence of metastases. What symptoms am I speaking of? We refer to them as a particular type of syndrome. What am I talking about? So systemic symptoms that are not clearly explained by either the mass effect of the primary tumor or by the metastases, or so not B symptoms. So B symptoms, we're talking about lymphomas when we go into that, and specific things, symptoms that characterize these, that fall into the category of B symptoms. So they are constitutional, they are systemic symptoms, but they're not explained by either the mass effect of the primary tumor or anything that the native cells of the primary tumor can produce, hint, hint, and not explained by metastases either. What am I talking about? So these systemic symptoms are caused by something else. So cachexia is a general feature of malignancies. I'm talking about these specific systemic symptoms. Okay, so they're ascribed to abnormal production of substances. I won't say what types of substances, they're a complete giveaway. So these substances are not produced by the native cells from which the tumors arise. These substances don't arise as a result of metastasis. So remember, we said that if you have metastasis to bone, the patient can have hypercalcemia. But is there any other way in which a patient with a malignancy could develop hypercalcemia? So not via bone metastasis. So what about it? Not true. Aha, okay. So paraneoplastic syndromes, fabulous. So in paraneoplastic syndromes, we have abnormal hormone production, and these substances that are elaborated are not normally produced by the native tissue from which the tumor arises. So if we had an a pheochromocytoma that was producing epinephrine and norepinephrine, that would not be a paraneoplastic syndrome because the cells of the adrenal medulla from which the tumor arises normally produce epinephrine and norepinephrine. But if we had a renal cell carcinoma that was causing hypercalcemia, and the hypercalcemia was not as a result of bone metastasis, then that's a paraneoplastic syndrome. What is it that the tumor cells are producing that is going to raise the calcium levels? So someone just posted an answer which was parallel to the answer. So it's not hyperparathyroidism per se, but what is it that the tumor cells are producing? So in other words, parathyroid glands are not producing increased PTH, right? That's not what's happening here. The tumor cells are producing a substance that is going to cause hypercalcemia. What is that substance? Relate. Aha. And what does that mean, Danielle? So parathyroid hormone related peptide. Fabulous. Okay. So the tumor cells produce a substance that is like parathyroid hormone, and it also has the ability, like parathyroid hormone, to elevate calcium levels. So that's one paraneoplastic syndrome that renal cell carcinomas can produce. So remember that in addition to the fact that these tumors cause widespread metastases commonly, they are also notorious for producing various different paraneoplastic syndromes, of which hypercalcemia is just one. What else can the tumor cells of renal cell carcinoma produce? What else can they cause? So we can get polycythemia, yes, and this is as a result of the production of, someone wrote, production of erythropoietin. Fabulous. So remember, yes, this tumor is arising in the kidney, but the cells that it's arising from are the tubular epithelial cells. It's not arising from the cells that normally produce erythropoietin. Therefore, it is a paraneoplastic syndrome. Um, Someone put renin, yes, and patients can have hypertension as a result. Fabulous. Anything else that these patients can develop? Yeah, paraneoplastic syndromes. Okay, so they could have Cushing syndrome, for instance, yes. It's an ACTH. All right, so takeaway from this renal cell carcinoma, a tumor that arises from tubular epithelial cells. Patients can present with the classic triadal symptoms that we outlined, but more commonly discovered um, through investigation of hematuria with which the patient presents. These tumors have different histological categories into which they fall, and remember, you're going to read more about those. The tumor may be sporadic or may occur as part of an inherited syndrome. The tumors metastasize widely. We spoke about some of the organs to which they go, and they're also notorious for producing a wide variety of paraneoplastic syndromes. All right, so now that we have discussed renal cell carcinomas, you can now go and read your lecture notes, read the text, and consolidate everything. So I'm going to show you another photo now, and you can tell me what you think this is. So which organ do you think it is, and what's happening? Another very interesting lesion, interesting pathology. Any takers? Remember, you can say anything in this session, right? It's not the exam. Say anything. We'll just say yes or no. Right? Fabulous, Henny. This is the angula. This is the adrenal gland. So why did you call it Ensenina? Why did you call it the adrenal gland? Tell me why. What made you say adrenal gland? Okay, yes, yes, that the shape, it kind of still has retained the shape, even though there's obviously something going on there. So the basic outline of the adrenal gland remains, yes. What color, Denny? Tell me, be more specific about the color. Which color are you telling me about? Talking about this color here? You can see that color. Denny? Yeah, so this bright yellow color representing which part of the adrenal gland? That bright yellow color. Cortex or medulla? So the cortex, okay, so the cortex shows this bright yellow color, fabulous. And remember, that is what we see on the outside. So this is the cut surface, right? So we still have bits of cortex here on the outside. And then in the middle is where we'd find the medulla. What's happening in the medulla? And extending out. What's happening in the medulla? What do you see in the medulla? Describe what's there. Okay, so I think we have some agreement that there is a mass that's occupying the medulla. What color is it? What's going on in it? Let's describe it a bit before we decide what it is. So we have these kind of tan looking areas, and we have areas of hemorrhage. Yes, okay, fabulous. So we have all these areas of hemorrhage, which are the red areas that you're talking about, right? And it's extending from the medulla, is going through the cortex. So based on the answers that you gave before, I see where you're thinking it's a neoplastic mass, and someone went further to say that it's malignant. We're going to discuss if we can tell from this whether this particular mass is benign or malignant. So we agree it's a neoplastic mass. So a neoplasm arising in the medulla is going to be what until proven otherwise in an adult patient. Let's say this is a person who is 32 years old. What would this most likely be? You've been telling me about it all session. Okay, pheochromocytoma, fabulous. So here is a pheochromocytoma. So if I took a section of this, before I ask you that, so it's arising from adrenal medulla. What types of cells do we have in the adrenal medulla? These cells arose from what embryonic structure? Okay, from neurocrest. So these tumors are basically neuroendocrine tumors, right? So we spoke about neuroendocrine tumors a bit earlier when someone brought up carcinoid. So pheochromocytoma is another type of neuroendocrine tumor. Okay, so if I took a section of this tumor and looked at it under a microscope, what would I see? How would the cells look? How would they be arranged? There's some classic features that would have been described in your lecture. How are the cells arranged? What type of stroma is present? So think that it's endocrine, if you're in a stroma. Remember that hormones are secreted into the what kind of stroma would these neuroendocrine tumors generally have? What would be prominent in the stroma? What structures would we see a lot of in the stroma? Now I was saying that the clue, aha, yes, so lots of vessels. So there's a very rich vascular network that forms a stroma of this tumor. And how are the cells arranged within that vascular network? Are they in papillae? Are they in nests? Are they in trabecula? Are they, what's a classic arrangement of cells in a pheochromocytoma? And also in other neuroendocrine tumors, they tend to have this arrangement. Fabulous. So we have these small nests of cells arranged within this rich vascular network, and we call that a Zell-Ballen pattern, remember? All right, so the individual cells now, how do they look? The nuclei in neuroendocrine tumors show this characteristic feature. What is that feature? Remember, in pathology, we like to make analogies to food. What type of pattern do we see in the nucleus, the nuclei of the cells? In pheochromocytoma and in other neuroendocrine tumors too. How is the chromatin arranged? What kind of pattern do we talk about? So no one remembers the term stippled chromatin? So we have these little bits of chromatin together with areas with none, and so we call it a salt and pepper arrangement. Okay, so that's what you'd see under the microscope for these pheochromocytomas. We already made reference to the fact that the tumors produce epinephrine and norepinephrine. So this catecholamine producing tumor arises from the adrenal medulla and has that particular histological appearance. How would patients with this tumor present? So there is presentation of hypertension. Remember that this is usually episodic or paroxysmal hypertension that these patients have. Okay, this is one of the classic symptoms that these patients have. These pheochromocytomas, you have told me, can be part of the von Hippel-Lindau syndrome. Are there any other syndromes that may have pheochromocytoma as a component? Okay, so some of the MEN syndromes, which ones? So there are two types of two. Okay, so yes, they both show pheochromocytomas. Both 2A and 2B have pheochromocytoma as a component. So what are the other components of MEN2A? What else do we get in MEN2A? Fabulous. So when you say medullary thyroid, Cal, what do you mean? Medullary thyroid what? Carcinoma. Okay, so medullary thyroid carcinoma. And when you say parathyroid, what do you mean? What's happening in the parathyroid? Okay, so parathyroid hyperplasia. Sometimes there can be adenoma, but it's most commonly hyperplasia, as you have stated there. All right, so those are the most characteristic features of MEN2A: pheochromocytoma, parathyroid hyperplasia, and the medullary thyroid carcinoma. What about MEN2B? Fabulous. So patients with MEN2B often display a marfanoid habitus. Yes, and they have mucosal neuromas. Fabulous. Often involved in places like the tongue, the lips, and internally we can find ganglioneuromas in the appendix. Fantastic. So they have these mucocutaneous neuromas, they have a marfanoid habitus. We know they have the pheochromocytomas because you told me that already. What else do they have? Do they have anything else in common with MEN2A? The medullary thyroid cancer. Fantastic. Right, so apart from VHL, MEN2A, MEN2B, do you know any other syndromes in which patients may have pheochromocytoma? Fabulous. So it can be associated with neurofibromatosis type 1, so NF1 or von Recklinghausen's. Okay, type 1. Okay, all right. Yes, type 1. Okay, all right, fantastic. So pheochromocytomas, you know, the histology can look quite ugly under the microscope and doesn't mean that it is malignant. So with these tumors, so there's a lot of debate always going on about how can you tell whether or not a pheochromocytoma is benign or malignant. And most people tend to say that the only true evidence of malignancy is if the tumor metastasizes. So with a lot of these neuroendocrine tumors, they can look quite ugly on histology and still be benign. So they're not, in other words, they're going to have a good prognosis. So with these tumors, it's very difficult to ascribe malignancy based on the histology. Okay, so that was pheochromocytomas. Let me just have one more thing to show you. See if you have been memorizing your weights and measures. So what are we showing in this photograph? This organ has been cut clearly. What are we seeing in this photograph? Fabulous, it's the heart. And what areas of the heart, what areas of, yes, Daniel, we're coming to that, but not hyperplasia, something else. This, where in the heart are we seeing? What are we seeing represented here and here? Yes, Daniel, hypertrophy, not hyperplasia. Okay, so we're seeing ventricles. So I see S, so we're seeing both of them. So which one is this one? Which ventricle is it? Well, left, and then clearly therefore this one must be the right ventricle. Okay, so we have gotten some measurements here. So this scale is this marker here is telling us that the thickness of the left ventricle in this heart is 20 millimeters. What do you have to say about that? Is that below the normal range, within the normal range, or above the normal range? Above. So what's the upper limit of normal? 15 millimeters. Fantastic. Okay. All right. So clearly, there is something that is causing an increase in thickness of the ventricular wall here. And I've seen offers that what's happening here is hypertrophy, which I would agree with. So this hypertrophy, the thickness of the wall is basically the same all around. Now we're not to measure the papillary muscle, which we can see here, right? So it seems as if all around it's about 20 millimeters. So someone had mentioned earlier that we can further characterize the hypertrophy by saying that it is concentric, meaning that the thickness is the same all the way around. All right, so I'd agree with that. So there is concentric hypertrophy of the left ventricle. So how would you define hypertrophy? I asked you to define hypertrophy. What would you tell me? Okay, so there's an increase in size of individual cells resulting in what? What's the net effect of the increase in size of the cells? The same net effect as hyperplasia. Increase in size of the organ or tissue. Fabulous. All right, so with hyperplasia, we also have an increase in size of organ or tissue, but the mechanism there is not increasing cell size. What is it instead in hyperplasia? Increasing the number of cells. Fabulous. Okay. All right, so it means therefore that if we're saying there's hypertrophy there, it should have resulted, well, it resulted in an increase in thickness of the left ventricle, and that could result in an overall increase in size of the heart. So is that reflected here? They have indicated here that the weight of the heart is 580 grams, and this is from a 65-year-old man. So what do you have to tell me about this weight of the heart in the 65-year-old man? Is 580 grams normal or abnormal? Okay, it's abnormal. So is it abnormal high or abnormal low? Okay, so this heart is heavier than it should be. What is the upper limit of normal weight for an adult, for heart in an adult male? How many grams? Fabulous, 350 grams, great. So it is clear that this heart is increased in weight, increased in size, it's exhibiting cardiomegaly, and the cause of the cardiomegaly we have identified as the left ventricular hypertrophy. So we said this hypertrophy was concentric. What is the commonest cause of concentric left ventricular hypertrophy? Hypertension, fabulous. What are some of the other things that can cause hypertrophy of the left ventricle? Whether we're talking about concentric or not, what can cause hypertrophy of the left ventricle apart from hypertension? Well, not exactly, Kyle. So hypertension can result in heart failure, and many other diseases can be complicated by heart failure, which is really just an end result of all these other diseases. So the thickness of the ventricle in heart failure will depend on what was causing the heart failure. Okay, so I saw some other answers. So someone said stenosis. Stenosis of what? So of the aorta, fine. So if there's aortic stenosis, either of the aortic valve itself, then we could have hypertrophy occurring. So tell me something. In the case of hypertension and aortic stenosis, why are the cells undergoing hypertrophy? What caused them to undergo hypertrophy? So, okay, if I put those answers together, we're saying that the left ventricle has to work harder to pump blood to the periphery through the aorta because of all these varying factors, either because there's increased pressure from the hypertension or because there's a stenotic valve. Okay, fabulous. So it's increased workload that is causing the cells to undergo hypertrophy. Okay, great. What other causes of hypertrophy can you think of? Pardon me, the internet went down just a bit in the department. Okay, so what other cause of hypertrophy? Okay, so it may, Kyle. Yes, it may. What else? Can you think of any other diseases that show hypertrophy of the left ventricle? Suppose a 19-year-old man is playing football. Oh, someone put the answer there. Okay, Daniel. I was trying to give you a scenario to come up with hypertrophic cardiomyopathy. Okay, fabulous. So yes, hypertrophic cardiomyopathy. Is there any difference in the type of hypertrophy that we see in hypertrophic cardiomyopathy compared to what we would see in hypertension? In other words, is the hypertrophy concentric in hypertrophic cardiomyopathy? No takers? Is it usually concentric? So think about how I've asked the question. Is it okay? Okay, Tavia and Danae, can it be concentric? Okay. Right. So in a small percentage of cases in hypertrophic cardiomyopathy, the hypertrophy is actually concentric, but in the majority of cases, it is not. So which area of the ventricle is thickened to a greater degree in hypertrophic cardiomyopathy? Is it the septal portion or is it the free wall of the left ventricle? So in other words, aha, yes, Daniel, Anthony, it's usually septal. So we talk about septal hypertrophy occurring in hypertrophic cardiomyopathy. All right, so we have all these other causes of hypertrophy. Can there be anything else apart from hypertrophy that could cause an increase in weight of the heart? What else could cause cardiomegaly? So what is DM representing here, Tanya? There are different DMs in medicine. What's that DM you have written there? Okay, so not so much, not specifically cause an increase in weight of the heart. But I guess you're thinking that diabetes affects vessels in general, it affects the vascular system. True, of course, with its accelerated atherosclerosis and so on, but not specifically causing cardiomegaly. Usually, if the diabetes is associated with hypertension, as it often is, then it's the hypertension that's causing the cardiomegaly. Anything else that could cause cardiomegaly? Okay, so honey, if the pericardial effusion is not going to cause an increase in weight of the heart. Remember, the pericardial effusion just means that there's fluid in the pericardial cavity. So on radiological imaging, you may think that it's increased heart size. That may be misinterpreted, but this is fluid, not an increase in the weight of the heart. So I see other answers here. So other cardiomyopathies may also cause an increase in heart rate. Yes. So dilated cardiomyopathy, for instance, yes. What other type of cardiomyopathy do we know of? So that other type may actually not affect the weight at all, or may actually have decreased weight, but could have increased weight as well. What's the other type? What's the third type of cardiomyopathy? The one that we haven't mentioned. Restrictive cardiomyopathy, yes. So if this restrictive cardiomyopathy is due to the deposition of something in the heart, like amyloid, for instance, we're adding something to the heart, So potentially that could cause an increase in weight. And remember that some types of congenital heart disease may also result in an increase in heart rate, depending on what particular features it has. So if there is, for example, stenosis of some valves, resulting in hypertrophy and so on, we could have an increase in heart rate. So there are many, many causes of cardiomegaly. In adult patients in this population, the commonest cause that we see would be left ventricular hypertrophy consequent on essential hypertension. All right, so I promised I wouldn't keep you beyond 1:35 for this longest session today. So please review everything we have discussed. We spoke about renal cell carcinoma and all the associated syndromes. We spoke about pheochromocytoma and associated syndromes. And we have now just discussed cardiomegaly, focusing a bit on hypertension as a common cause of this entity. Are there any questions? Okay, so please know that we have discussed this. Please go and read everything over again. I find that after discussing something and then going back to the text of the lecture notes and reading it, it just helps to consolidate it in your mind. So all that's left for me to say is have a good weekend, and we will see you next week. Oh, Sunina has a question here. Can ion channel disorders cause cardiomegaly? So that depends on what specifically, what ion channel disorder are you talking about? So remember that we can have monogenic forms of hypertension that are due to an ion channel disorder. So if that's where you're going, then the answer would be yes. So it would depend on what disorder you're thinking of, right? Because there are many disorders, diseases due to defective ion channels. So it just depends on what you mean. I hope that helps. Okay, fabulous. All right, any other questions? You're welcome. All right, so off to enjoy the weekend. Remember still to do some reading. There's a lot of volume to cover in pathology and microbiology. Thanks, Carol. But nonetheless, have a good weekend. Thank you. You're welcome.